Welcome to the deep dive. Okay, let's unpack this. Imagine a process happening inside your body, like right now. It's silent, often totally unseen, but it's fundamentally shaping your future health.
hmm
It's tied to what we eat, how we live, and it's a leading cause of death in Western countries.
hmm
We're talking about dyslipidemia and its critical connection to conditions like atherosclerosis.
Yeah, that's right. And what's really fascinating here is that dyslipidemia isn't just about high cholesterol like most people think. It's actually a complex metabolic disorder. It involves various types of plasma lipids, fats that are transported in these special carriers called lipoproteins.
Okay.
So today we're going to break down these complexities. We want to give you a master level understanding, kind of like the elite professionals in this field have.
That's exactly our mission today. To give you a shortcut, sort of to being truly well-informed,
Yeah.
we'll be sifting through the layers of scientific detail, pulling directly from medical textbook excerpts, clinical
Your
research.
core stuff.
It's exactly, bringing out the most important nuggets of knowledge. We'll cover the basics, the pathophysiology, diagnosis, and the huge range of treatments from lifestyle changes right up to the cutting-edge drugs. Let's get ready to really master this topic.
All right, so to really get a handle on this, we absolutely have to start with the basics, the lipids themselves and the vehicles that carry them around.
The delivery truck.
Exactly, the delivery trucks. So when doctors talk about elevated levels of any kind of lipoprotein, the general terms you'll hear are hyperlipoproteinemia or hyperlipidemia.
Okay, broad term.
Right, but here's an important distinction. If we're talking specifically about increased levels of triglycerides, the more precise term is hyperlipemia.
Ah.
And this difference isn't just, medical jargon. It's crucial because while both mean there's a lipid imbalance, they can cause different problems and often need different treatments.
That makes total sense. Okay, so lipids, cholesterol, triglycerides, they're basically fats, and fat and water don't mix, right? But our bloodstream is mostly water. So how does the body ferry these, essential but water-hating fats around without them just clumping up?
That is the brilliant part. That's where lipoproteins come in. Think of them, like you said, as these tiny, super sophisticated delivery trucks. They package the fats safely so they can travel through the watery bloodstream, dropping off their cargo where it's needed.
Ingenious.
It really is. And each of these lipoprotein trucks has a specific design. At the center, there's this hydrophobic core, meaning it hates water, and it's packed with cholesterol esters and triglycerides. Those are the main forms of fat we carry.
The cargo.
The cargo. And then this core is wrapped in a more water-friendly outer shell. This shell is made of unesterified cholesterol, phospholipids, and crucially, apoproteins.
Okay, apoproteins.
Yeah, and these apoproteins aren't just structural bits. They're like the ID tags or, the GPS systems for each lipoprotein. They tell the body where to send it and how to handle the cargo inside.
So these apoproteins are the real movers and shakers behind the scenes, determining how each lipoprotein acts. Sometimes for good, sometimes not so good.
Precisely.
Let's zoom in on the main players then, starting with one that's often, central to the problem. Apolipoprotein B100, or ApoB100.
Right. This one's made only in the liver, and you find it on let's call them the bad actors of the lipoprotein world.
Like LDL.
Exactly. Low-density lipoproteins, LDL, but also intermediate-density lipoproteins, IDL, very low-density lipoproteins, VLDL, and another one called lipoprotein A, or LPA.
Okay.
And ApoB100's job is pretty specific.
Oh.
It helps deliver lipids into the artery wall. It's literally laying the groundwork for those atherosclerotic plaques.
Wow. So that's a key point. It's not just LDL, it's any lipoprotein with ApoB100 on it that can contribute to that buildup.
That's a critical insight, yes. Now, building on that, we also have a apolipoprotein B48, ApoB48. This one's different. It's made in your intestine, not the liver.
Ah, from food then.
Primarily related to dietary fat transport, yes. You find ApoB48 mainly on chylomicrons and what are called their remnants. Chylomicrons are the particles that carry fat from your diet. And while that's their main job, these ApoB48 containing remnants can also get into the artery wall, adding to that atherosclerotic burden. So whether it originates in the liver with ApoB100 or the intestine with ApoB48, these ApoB proteins signal a potential risk for getting into the artery wall.
Got it. Okay, so those are the ApoBs. What about the good guys? Is there an Apo something for HDL?
There is indeed. That's apolipoprotein AI, or ApoAI. This is the main protein found on high-density lipoproteins, HDL. Its presence is absolutely vital for HDL's crucial role in reverse cholesterol transport, basically. The body's cholesterol cleanup crew. We'll definitely dig into that more.
Sound good.
And while ApoB and ApoAI are the headliners, we should probably give a quick nod to others like ApoC2, ApoAV, and ApoC3.
Minor characters.
They might seem like it, but they play really important kind of subtle roles. They regulate enzymes involved in breaking down lipoproteins, affecting how quickly these particles get cleared out. Understanding them just adds another layer to this whole metabolic picture.
Okay, that makes sense. So we've met the key tags, the apoproteins. Now let's look at the actual trucks, the different lipoprotein species themselves.
Yeah.
Each one has a different job.
Right?
And a different impact on health.
Exactly. People often hear good and bad cholesterol, but to really master this, we need to get a bit more specific.
We'll do it.
Okay, first up, chylomicrons. These are pretty amazing, actually. They get assembled in your intestine right after you eat, especially a fatty meal.
Right.
Their main mission. Transporting triglycerides and cholesterol that came directly from your diet. They take this interesting route first into the lymphatic system through the thoracic duct, and then eventually they pop out into your bloodstream.
Okay.
Once they're circulating, their triglycerides get broken down very efficiently by an enzyme system called lipoprotein lipase, or LPL. It basically pulls the fat out for energy or storage.
Right.
As they lose triglycerides, the chylomicrons shrink, and they transfer some surface stuff and smaller apoproteins over to HDL. The leftovers, these smaller particles called chylomicron remnants, are then quickly snapped up and cleared by the liver.
So chylomicrons handle the dietary fat. What about the fat your liver makes itself?
Good question. That's where very low density lipoproteins, or VLDL, come in. Your liver secretes these. Their main job is to export hepatic triglycerides, fat made in the liver, out to your peripheral tissues, like muscles and fat cells.
For energy or storage there.
Exactly. And just like chylomicrons, VLDL triglycerides also get broken down by LPL. As VLDL particles shed their fat cargo, they transform into smaller particles called intermediate density lipoproteins, or IDL.
Okay, IDL. The intermediate step.
Right. Some of these IDL get taken up directly by the liver, but a lot of them get processed further by another enzyme called hepatic lipase. And this enzyme converts IDL into our main bad cholesterol carrier, low-density lipoproteins, or LDL.
Ah, so VLDL becomes IDL, which becomes LDL. That's the pathway.
That's the main endogenous pathway, yes. And it helps explain something we sometimes see clinically. If someone has super high triglycerides and we treat them aggressively, their VLDL drops, but sometimes their LDL actually goes up temporarily. It's called the beta shift. It's just because the remaining particles are now mostly LDL.
Interesting. Okay, so that brings us to LDL, the one everyone talks about, the primary target.
Precisely. Low-density lipoproteins, LDL, formed mainly from that VLDL breakdown. Now, how does the body get rid of LDL? Mostly through special receptors on the surface of liver cells and other cells too. It's a process called receptor-mediated endocytosis.
The lock and key thing again.
Exactly. ApoB100 on the LDL particle is the key, and the LDL receptors on the cell are the locks. Once LDL gets inside the cell, the cholesterol esters it carries are broken down, releasing free cholesterol.
What do cells use that cholesterol for?
Essential stuff like building and repairing cell membranes. Your body also has its own internal cholesterol factory, regulated by an enzyme called HMG-CoA reductase. Both this enzyme and the number of LDL receptors are tightly controlled by how much cholesterol is already inside the cell.
Makes sense. A feedback loop.
Exactly. And here's a really critical point. The liver is the only organ that can actually eliminate cholesterol from the body. It does this either by secreting cholesterol directly into bile or by converting it into bile acids, which then help with digestion. Understanding this is fundamental.
Wow, okay. Only the liver can truly get rid of it.
Got it.
Now, what about this other one you mentioned, LPA? That sounded complicated.
It is a bit more complex. Lipoprotein, or LPA, it's basically an LDL particle, but it has this extra protein attached called the A protein, linked by something called a disulfide bridge.
Okay. What's special about the A protein?
What's really intriguing is how similar it looks structurally to plasminogen. Plasminogen is key for breaking down blood clots. But here's the twist. Unlike plasminogen, the A protein is missing the spot where tissue plasminogen activator, TPA, normally binds to activate it. So LPA can't actively dissolve clots.
So it looks like a clot buster, but isn't one.
Kind of. And your LPA level is mostly set by your genes, varying a lot from person to person. Clinically, we find LPA accumulates in those atherosclerotic plaques. It contributes to coronary artery disease not just by being there, but by actually inhibiting thrombolysis, your body's natural clot dissolving process.
So it promotes plaques and stops clots from breaking down. That sounds like double trouble.
It is. It increases risk for heart attack and stroke, and it's also specifically linked to aortic stenosis, which is a narrowing of the aortic valve in the heart. Managing high LPA is tricky, though new therapies are being developed. Aspirin might offer some protection against the clotting risk, though.
Okay, good to know.
Yeah.
All right, finally, let's get to the hero HDL.
Yes, high-density lipoproteins, or HDL, often called the anti-atherogenic hero. The main apoproteins for HDL, like ApoAI, are mostly secreted by the liver and intestine. A lot of HDL's lipid content actually comes from scavenging leftover bits from other lipoproteins as they get broken down.
Recycling.
Sort of, but its main claim to fame is being the cholesterol cleanup crew. It picks up excess cholesterol from cells in peripheral tissues, basically protecting them from overload. This amazing process is called reverse cholesterol transport.
How does that work?
Well, it starts when free cholesterol is shipped out of cell membranes, mainly by a transporter called ABCA1. This cholesterol gets picked up by a small, newly formed HDL particle. Then, an enzyme called LSAT quickly converts that free cholesterol into a cholesterol ester, which is a more stable form.
Okay.
Other transporters like ABCG1 and SRBI also help load cholesterol onto larger HDL particles. These cholesterol esters then often get transferred over to those ApoB-containing lipoproteins, VLDL, IDL, LDL, with help from another protein called CETP.
So HDL passes the cholesterol off.
Often, yes. And eventually, that cholesterol makes its way back to the liver via those other lipoproteins for elimination. HDL can also deliver cholesterol esters directly to the liver using that SRBI receptor, kind of a shortcut.
Wow, that's a really intricate system for cleaning up cholesterol.
It absolutely is.
So the bottom line usually is higher HDL cholesterol, or HDLC, is generally linked to lower risk of atherosclerosis, right? That inverse relationship.
Generally, yes, at a population level that holds true. But here's where it gets really nuanced, and this is a critical takeaway for you listening. Even if two people have the exact same HDLC number on their lab report, the actual functional capacity of their HDL to accept and remove cholesterol can be very different.
So it's not just the quantity, it's the quality.
Exactly. This individual difference in HDL's function, its cholesterol acceptor capacity, is increasingly seen as a really major factor in coronary atherosclerosis risk. Maybe even more important than just the HDL number itself.
That's huge.
Yeah. And we zoom out again, understanding this whole dance, how these lipoproteins are made, what they carry, how they're cleared. It's absolutely fundamental. It sets the stage for understanding dyslipidemia and why it's such a big deal for our health. We're looking at a dynamic system, not just numbers.
Okay, so we've got the building blocks down. Now, the big question, why? Why does this complex system matter so much? What happens when it goes wrong?
Right. The major clinical consequences, the things we really worry about with hyperlipidemia, basically boil down to two main, very serious conditions: acute pancreatitis and atherosclerosis.
Let's start with pancreatitis.
Okay, acute pancreatitis. This is a direct, often life-threatening result of marked hyperlipemia, specifically when triglyceride levels get incredibly high. We're talking levels so high the body just can't clear them fast enough.
How high are we talking?
Often well over 1,000 mg/dL, sometimes much higher. It's an agonizingly painful condition, can lead to really severe complications, and needs immediate medical help. The key insight here is that by strictly controlling those triglyceride levels, preventing them from skyrocketing, you can effectively prevent recurrent attacks. It's a very clear cause and effect.
Wow. Okay, that's a strong reason to manage triglycerides. But the other one you mentioned, atherosclerosis, that feels more, I don't know, widespread.
It is atherosclerosis, the silent killer. It's this chronic inflammatory disease where fatty plaques slowly build up inside your arteries. And yeah, it's not just a concern, it is the leading cause of death for both men and women in the US and many other Western countries. Understanding how it develops is absolutely vital.
So how does that plaque actually form? What's the process?
It's a complex sequence, the pathogenesis of atheroma or plaque formation. It really starts when those ApoB100 containing lipoproteins, LDL mainly, but also IDL, VLDL, LPA, and those ApoB48 chylomicron remnants manage to get into the artery wall.
They squeeze through the lining.
Essentially, yes. They're not really supposed to be there in large amounts. And their presence kicks off this whole inflammatory cascade.
Okay, so they're inside the wall. Then what?
Then you get the cellular transformation. Macrophages, which are a type of immune cell, get called to the scene. They start gobbling up these lipoproteins, especially ones that have been chemically damaged or modified, and they turn into what we call foam cells.
Foam cells, because they're full of fat.
Exactly. They look foamy under a microscope. And smooth muscle cells that are normally in the artery wall also start taking up cholesterol esters. This whole process is driven partly by scavenger receptors on these cells, which recognize and take up these modified lipoproteins.
So the cleanup crew accidentally makes things worse.
In a way, yes. And as these foam cells and lipids accumulate, the plaque just grows. It becomes this complex mix of foam cells, fibrous tissue like collagen, fibrin, calcium. It gets quite complicated.
And this narrows the artery.
Over time, yes, these growing plaques can slowly narrow the artery, restricting blood flow. That's one problem. But here's what often causes the really sudden acute events like heart attacks or strokes.
That's that.
It's the rupture of unstable plaques. The plaque breaks open, exposing its inner contents, which are highly thrombogenic, meaning they trigger clots to the bloodstream. This causes platelets to activate rapidly, forming a blood clot, a thrombus, right there, which can suddenly block the artery completely.
Wow. So it's not always the slow narrowing, it's often the sudden rupture.
That's what causes the majority of acute events, yes.
Yeah.
And this brings us to a really important point about the impact of treatment. We know aggressive lipid-lowering therapy can, over the long term, lead to a slow physical shrinking of these plaques.
Right.
But the really remarkable thing is the rapid reduction in heart attacks and strokes we see, sometimes within just 2 or 3 months of starting strong treatment. This rapid benefit is thought to be mainly due to reducing the inflammatory activity within the plaque, particularly from those macrophages.
So it's like calming the inflammation makes the plaque more stable, less likely to rupture.
Exactly. It's not just about shrinking the plaque size immediately. It's about putting out the fire that makes it dangerous and unstable. That's a critical distinction and explains why starting treatment early and aggressively is so effective.
Makes sense. And it's usually not just about lipids alone, right? Other factors play a role.
Absolutely. Atherosclerosis is definitely multifactorial. Let's touch on some major risk factors and their mechanisms. Cigarette smoking is a huge one, just devastating for arteries.
How so?
Well, it lowers your good HDL. It impairs the body's ability to pull cholesterol out of the artery wall. It's directly toxic to the endothelium, that delicate inner lining of blood vessels. And crucially, it increases the oxidation of those atherogenic lipoproteins, making them even more likely to be taken up by foam cells.
Wow.
Plus, it promotes clot formation, thrombogenesis. It's bad news all around.
Okay. What else? Diabetes.
Diabetes is a major source of oxidative stress in the body. That stress damages lipoproteins, accelerating plaque formation. And hypertension, or high blood pressure, adds significant mechanical stress to the artery walls, making them more prone to injury and lipid buildup.
It's like a perfect storm of factors.
It can be. And one fascinating player that connects to all this is nitric oxide. Normally, your coronary arteries can dilate or widen thanks to nitric oxide signaling smooth muscle cells to relax. This increases blood flow when needed, like during exercise.
Right.
But here's the problem. Those atherogenic lipoproteins actually impair this nitric oxide release. So your arteries can't dilate properly when they need to, which makes ischemia or lack of blood flow worse.
But can treatment help that?
Yes, and this is powerful. Reducing those atherogenic lipoproteins and stopping their oxidation can actually restore that endothelial function, allowing arteries to dilate properly again.
That's fantastic.
Yes.
So it really drives home that this is a multifactorial process, doesn't it?
Absolutely. It's dynamic. It involves inflammation, lipids, blood pressure, blood sugar, smoking. Everything interacts, which means therapy has to target all the modifiable risk factors you can address.
And the evidence supports this.
Overwhelmingly. Angiographic trials where they actually look at the arteries show plaque regression with aggressive therapy. And the big prevention trials clearly show significant reductions in deaths from heart events and overall mortality. Managing these factors saves lives.
So the big takeaway here is, this isn't just about a number on a lab report. It's about understanding this cascade of events that leads to potentially life-threatening conditions.
Exactly. It's about seeing the whole picture and understanding the immediate, profound impact that managing these lipids and risk factors can have.
Okay, we know why it matters.
Yeah.
Now, how do we actually figure out who has dyslipidemia and what kind? How do we diagnose and classify it?
Right, the practical side. The standard starting point is measuring lipids in a blood sample, usually serum, after about a 10-hour fast. This gives us that crucial snapshot of lipoprotein levels.
And what are we looking for?
Generally, the risk of heart disease goes up as those atherogenic lipoproteins LDL, VLDL, IDL, LPA increase, and it goes down as HDL-C increases. But of course, that risk is always modified by all those other factors we just talked about: smoking, diabetes, hypertension, family history.
Okay. Are there ideal target levels?
Clinical trials give us pretty good guidance. An LDL cholesterol, or LDL-C, level around 50 mg/dL seems optimal, especially for patients who already have coronary or peripheral artery disease. For triglycerides, the goal is typically under 120 mg/dL.
And LDL is the main target.
LDL-C is usually considered the primary treatment target in most guidelines, yes. But reducing VLDL and IDL is also really important for overall cardiovascular health because they definitely contribute to plaque.
Got it. Now, before jumping to a diagnosis of a primary, maybe genetic disorder, what's the first step?
Crucially, you always need to rule out secondary causes. There are many common conditions and even medications that can mess up lipoprotein levels.
Like what?
Oh, things like poorly controlled diabetes, hypothyroidism, an underactive thyroid, heavy alcohol use, certain kidney diseases like nephrosis, liver issues like cholestasis, even some drugs like certain HIV protease inhibitors or transplant meds like tacrolimus and sirolimus.
And if you treat the underlying cause?
Exactly. The powerful insight here is that if you successfully treat that underlying disorder, the lipid abnormality often just resolves on its own. No specific lipid drug needed.
That's important.
And another key point, these secondary causes can also amplify a primary genetic disorder, making it look much worse than it would be otherwise. Oh, and just a quick side note, there's a rare genetic thing called glycerol kinase deficiency that can cause falsely high triglyceride readings. It needs special lab tests to spot.
Good to know. Okay, so assuming we ruled out secondary causes, let's dive into the primary hypertriglyceridemias. High triglycerides themselves are a risk factor, right?
Yes, definitely an independent risk factor for coronary artery disease. We actually find chylomicrons, VLDL, and IDL right inside atherosclerotic plaques.
Proof they're involved.
Exactly. And interestingly, patients with high triglycerides often have VLDL particles that are kind of abnormal, smaller, but richer in cholesterol. And they also tend to have small, dense LDL particles. Both of those are thought to be more atherogenic, more likely to cause plaque.
So treatment is important.
Aggressive treatment is essential, especially for those who already have heart disease or equivalent risks. And here's a critical number to remember. If triglycerides go above 700 mg/dL, treatment is absolutely mandatory to prevent acute pancreatitis.
Why 700?
Because at those really high levels, the LPL system, the enzyme that clears triglycerides, just gets completely overwhelmed. It's saturated, and the fat builds up dangerously in the blood.
Okay. And high triglycerides often go hand in hand with other issues, right? Like metabolic syndrome.
Very much so. Hypertriglyceridemia is a key part of the metabolic syndrome, which also includes insulin resistance, high blood pressure, and abdominal obesity. You also typically see low HDL-C in these folks.
Why is HDL low?
It's largely due to an increased exchange of cholesterol esters out of HDL and into those triglyceride-rich lipoproteins. It's like HDL is giving away its good stuff. You also often see high uric acid, hyperuricemia.
And insulin resistance is often the root cause.
It's a very common underlying factor, yes, which is why managing insulin resistance with diet, exercise, sometimes metformin, is so important. The big takeaway is that the severity of any hypertriglyceridemia gets significantly worse if metabolic syndrome, type 2 diabetes, or even just regular alcohol use is also in the picture. They compound each other.
Makes sense. Okay, let's get specific. What are some of the key primary hypertriglyceridemias?
All right. First, there's primary chylomicronemia, also called familial chylomicronemia syndrome. Normally, after fasting, you shouldn't have any chylomicrons in your blood.
Right.
But in this rare, severe genetic condition, they're sky high. It's usually caused by recessive mutations, meaning you need 2 bad copies of the gene affecting the LPL itself, or its helper protein ApoC2, or other key players like LMF1, CRAP3L3, or GPI-HBP1.
So the clearing mechanism is broken.
Severely broken. This leads to profound lipemia, triglycerides often over 1,000 mg/dL, sometimes way higher even on a normal diet. ApoAV mutations can also play a role.
When does it usually get diagnosed?
Often, tragically, not until someone has an attack of acute pancreatitis, or sometimes during pregnancy because estrogen makes it worse. Clinically, you might see things like eruptive xanthomas, little yellow bumps on the skin, an enlarged liver and spleen, maybe lipemia retinalis, where the blood vessels in the eye look creamy.
Wow.
Diagnosis can be confirmed by measuring LPL activity after giving heparin, or sometimes just by seeing a huge drop in triglycerides after a few days of extreme dietary fat restriction. The absolute cornerstone is incredibly strict dietary fat restriction, maybe down to 10-20 grams a day, plus weight control, exercise, no alcohol. If VLDL is also high, maybe a fibrate, niacin, or fish oil. There's also a newer drug, melanosorcin, an ApoC3 antisense therapy approved in Europe. And for acute pancreatitis, plasmapheresis filtering the blood can be life-saving.
Intense. What's next?
Then there's familial hypertriglyceridemia. This one's much more common, often polygenic, multiple genes involved, and frequently linked with central obesity and insulin resistance. The issue here is both impaired removal of triglyceride-rich lipoproteins and overproduction of VLDL by the liver. Often results in a mixed picture.
Symptoms.
Variable. Can range from none to xanthomas, pancreatitis risk, depending on severity. Treatment here is primarily dietary weight loss, calorie restriction, alcohol avoidance are key. Marine omega-3s, especially EPA-only forms like Vasepa, can be very helpful, particularly for those with heart disease risk. If LDL is also up, a statin might be needed. Fibrates are usually reserved for triglycerides over 500 to prevent pancreatitis. Niacin could be an option if there's no major insulin resistance, and metformin helps if insulin resistance is present.
Okay. What about familial combined?
Familial combined hyperlipoproteinemia, FCH, very common, strongly linked to increased coronary risk. The genetics are complex, likely multiple genes. The hallmark of FCH is its variable lipid pattern. A person might have high VLDL or high LDL or both, and it can even change over time in the same person. But the one consistent finding is usually an elevated ApoB100 level.
The marker for those risky particles.
Exactly. It's usually dominant inheritance, involves maybe double the normal VLDL secretion. Elevations are often moderate. And here's the key insight for management. Diet alone is almost never enough for FCH.
Needs drugs.
Almost always. Often a statin alone, or maybe a statin plus niacin or fenofibrate.
Right.
Quick tip. If combining fenofibrate and a statin using pradastatin or rosuvastatin might be safer as they avoid the CYP3A4 pathway, reducing interaction risks. Omega-3s can help too.
Good practical tip. Okay, one more triglyceride one.
Yes, familial dyslipidemia. This one has a really distinct pattern. You get an accumulation of remnants from both chylomicrons and VLDL. But interestingly, LDL levels are often low. Because these remnants are packed with cholesterol esters, a big clue is when the total cholesterol level is almost as high as the triglyceride level. Diagnosis is often confirmed by genetic testing, looking for the ApoE2E2 genotype, meaning they lack the usual ApoE3 or E4 forms needed for proper remnant clearance.
What are the clinical signs?
Very characteristic xanthomas tuberous ones, and especially planar xanthomas, these yellowish streaks in the palm creases. Obesity, impaired glucose tolerance, hypothyroidism can all make it worse, and there's a high risk of both coronary and peripheral vascular disease. Often responds remarkably well to lifestyle changes, weight loss, reduced fat cholesterol, alcohol. Statins are usually very effective because increasing LDL receptors also helps clear these remnants. Fibrates are sometimes needed too.
Fascinating how distinct these are. Okay, let's switch gears to the primary hypercholesterolemias, where LDL is the main issue.
Right. The classic one is LDL receptor deficient familial hypercholesterolemia, FH. Very common genetic condition. Autosomal dominant, only need one bad gene. LDL starts rising in childhood.
How high does it get?
In heterozygotes who have one bad gene, cholesterol is typically 260-400 milli-GDL, triglycerides usually normal. They often develop tendon xanthomas, maybe arcus cornea around the eye, xanthelasma on eyelids, and importantly, premature coronary artery disease is a major risk.
And if you get two bad genes?
Homozygotes?
Much more severe. Cholesterol can be 500, even over 1,000 milli-GDL. Heart disease often starts in childhood, tragically. Severe early xanthomas are common, also aortic stenosis. Treatment is really complex.
What works?
Heterozygotes often respond well to statins, maybe with ezetimibe or other combos. Homozygotes are those with very little receptor function, only partially respond to standard drugs. This is where the newer agents, lamidipide, PCSK9 inhibitors, evinacumab, are absolute game changers.
Wow.
LDL apheresis, filtering the blood, is sometimes needed for the toughest cases.
Okay. What else causes high LDL?
There's familial ligand defective apolipoprotein B100. Here, the LDL receptor is fine, but the ApoB100 key on the LDL particle itself is defective, so it can't bind properly to the receptor.
So LDL can't get cleared effectively. Exactly. Leads to moderate hypercholesterolemia, sometimes tendinxantomas. Statin response can be variable here because making more receptors doesn't help if the LDL can't bind to them. Fibrates or niacin might work better by reducing VLDL production upstream.
Interesting. And the PCSK9 connection.
Right, PCSK9 gain of function. Normally, PCSK9 protein helps degrade LDL receptors. If you have a mutation making PCSK9 overactive gain of function, it destroys too many receptors. Fewer receptors mean higher LDL.
And we can target that now.
Yes, with PCSK9 antibodies, which is a huge breakthrough. Then there are LDL-RAP1 variants causing autosomal recessive hypercholesterolemia. The RAP1 protein helps get the LDL receptor complex into the liver cell. If that's defective, LDL builds up, looking a bit like homozygous FH. Statins and resins can often help these patients.
Okay. Any others?
CYP7A deficiency. This enzyme is the first step in converting cholesterol to bile acids. If it's deficient, cholesterol builds up in the liver, which then downregulates LDL receptors, raising plasma LDL. Homozygotes have higher LDL, maybe high triglycerides, early heart disease, gallstones, and are often statin resistant. Niacin plus a statin can work well here. And remember, some FCH patients just present with high LDL.
Right, the variable one.
Then LPA, hyperlipoproteinemia again, the genetic disorder causing high LPA production. Increased atherosclerosis and clot risk. Niacin can lower it. PCSK9 inhibitors lower it about 25%. And specific LPA antisense drugs are in late-stage development, which is very exciting. The goal is usually aggressive LDL lowering plus maybe low-dose aspirin.
Okay, what about the really rare storage diseases?
Cholesterol ester storage disease, CESD. Lack of lysosomal acid lipase, LAL enzyme, means cholesterol esters build up massively in the liver and macrophages. Causes enlarged liver, fibrosis, accelerated atherosclerosis, high LDL, very low HDL, maybe high triglycerides. There's a severe infant form, Wolman disease. The amazing news is there's now enzyme replacement therapy, sabellipase alpha, which can normalize lipids and reverse the liver disease.
Incredible. And phytosterolemia, plant sterols.
Phytosterolemia, defects in ABCG5G8 transporters that normally pump plant sterols out of the body. Mutations cause plant sterols to build up, leading to LDL enriched with them, xanthomas, early atherosclerosis. Standard cholesterol tests can be misleading here. The specific treatment is ezetimibe, which blocks sterol absorption.
Wow. Okay, we've covered high LDL and high triglycerides. What about low HDL deficiency?
Right. There are rare genetic disorders like Tangier disease or LCAT deficiency causing extremely low HDL. More common is familial hyperlipoproteinemia, often due to ABCA1 mutations leading to HDL below 35 or 45 milligl. These folks often get premature atherosclerosis. Sometimes low HDL is their only risk factor.
So low HDL is bad. Is very high HDL always good?
Interestingly, no. Here's a paradox. HDL levels above 90 milligdl have actually been linked to an increased risk of atherosclerotic disease in some studies, potentially related to variants in the SCARB1 gene. It really highlights that HDL function might be more important than just the level.
Fascinating. So how do you manage low HDL?
Main focus is aggressively managing all other risk factors. Niacin raises HDL the most, but its impact on outcomes in isolated low HDL isn't fully clear. Statins and fibrates have less effect. The key is still aggressive LDL and VLDL reduction. And remember, if triglycerides are high, treating them often raises HDL naturally.
Okay. This deep dive really shows the complexity. It's definitely not one size fits all. Understanding these nuances is key to mastering this field.
Absolutely. And before we even think about reaching for the prescription pad, it is so crucial to hammer home that dietary and lifestyle changes are the foundation. They're the first line of defense.
Always start there.
For many people, yes, especially if they don't have obvious heart disease yet. These changes might be enough to avoid drugs altogether. However, and this is a critical takeaway for patients with clear genetic hypercholesterolemias like FH.
Diet isn't enough.
Diet and lifestyle are always essential, but they will always need medication too. It's a combined approach, not either.
Okay. So what are the key dietary factors we need to watch? What raises lipids?
For raising LDL, the main culprits are dietary cholesterol from animal foods, saturated fats, think red meat, butter, processed foods, and trans fats, often in baked goods and fried stuff.
Got it. What about VLDL, the triglycerides?
Total fat intake matters, but also, surprisingly perhaps, simple sugars like sucrose and especially fructose can really drive up VLDL production. And alcohol is a big one. It directly increases the liver's output of VLDL, causing significant hypertriglyceridemia in susceptible people.
And just eating too much in general.
Yes, excess calories, regardless of the source, boost VLDL synthesis and secretion. But the flip side is powerful. Weight loss can dramatically lower both LDL and VLDL. Quick tip. Always wait until weight stabilizes for about a month before judging the effect of diet changes on lipids, as fluctuations can skew results.
Good point. So what are the general dietary recommendations?
Typically, guidelines suggest aiming for total fat intake around 20–25% of daily calories. Saturated fat should be less than 7%. Dietary cholesterol under 200 milligrams a day.
What kind of results can you expect from that?
Often a 10–20% drop in serum cholesterol, which can be significant. The focus should be on complex carbs, lots of fiber from fruits, veggies, legumes, and choosing healthier fats like cis monounsaturated fats from olive oil, avocados, nuts.
And for high triglycerides specifically?
Weight reduction, overall calorie restriction, and avoiding alcohol are absolutely key and often highly effective. Lifestyle really shines there.
Now, what about omega-3 fatty acids, fish oils?
Yeah.
They get talked about a lot.
Yes, and for good reason. They come from fish oils. Their main mechanism involves activating a receptor in cells called PPAR-alpha. This can lead to really profound triglyceride reduction in some people.
Beyond lipids.
They also have anti-inflammatory and anti-thrombotic effects, which are great bonuses for heart health. There are prescription forms available, like Lovasa, which has both DHA and EPA, and then there's an EPA-only form, icosapent ethyl or Vascepa.
Vascepa.
Yes, large trials showed it significantly reduces triglycerides and major cardiovascular events, which is huge. Part of how it works is by reducing ApoC3, which normally inhibits LPL, so it helps clear triglycerides more efficiently. Very targeted.
Very cool. Are there situations needing even stricter diets?
Yes, for the most severe conditions like primary chylomicronemia or some severe mixed lipemias, you need extreme fat restriction, maybe only 10–20 grams of total fat per day. And you have to ensure they get enough essential fatty acids and supplement fat-soluble vitamins A, D, E, K because intake is so low.
Wow, that's tough. Okay, beyond lipids, are there other dietary things affecting artery health? You mentioned homocysteine.
Right, homocysteine. It's an amino acid, and when levels are high, it can damage the endothelium, that artery lining. Levels can often be lowered by restricting total protein intake just to what's needed. For severe cases, supplements like folic acid, B vitamins, and betaine are used.
Why is it extra important with LPA?
Because high homocysteine can actually interact with LPA and make it more likely to cause clots. It's a nasty synergy.
And red meat.
Minimizing red meat is also advised, mainly to reduce production of TMAO, trimethylamine oxide, by gut bacteria. TMAO seems to be directly harmful to arteries. So you see, mastering this field means looking beyond just drugs. It's this holistic view of diet, lifestyle, genetics, everything interacting.
All right, lifestyle is the foundation. Now let's dive into the pharmacological arsenal. Making the decision to start a drug is complex, right?
It is. It's based on the specific lipid problem, the patient's overall risk for atherosclerosis or pancreatitis. Combination therapy is often used and generally safe if monitored properly, and critically, diet must always continue alongside the drugs.
Good reminder. Any major contraindication?
Yes. Generally avoided in pregnancy, lactation, or women planning pregnancy, and doses of anticoagulants often need adjusting when lipid drugs are started or stopped.
What about kids?
Children with heterozygous FH might get a resin or a statin, but usually statins aren't started until around age 8, after brain myelination is mostly done. The decision depends on LDL levels, family history, age. But kids with homozygous FH or the chylomicronemia syndrome need treatment right away at diagnosis because it's so severe.
Okay, let's start with the big guns. Reductase inhibitors, the statins. Everyone's heard of these.
Yes. Drugs like lovastatin, atorvastatin, fluvastatin, pravastatin, simvastatin, rosuvastatin, pitavastatin, their main job, lowering LDL cholesterol, often dramatically.
But they do more than that, right? These pleiotropic effects.
Absolutely. That's a key insight. They also decrease oxidative stress, reduce vascular inflammation, and make existing plaques more stable, less likely to rupture. There's even emerging data on other benefits, fighting certain viruses, helping with fatty liver or IBS, maybe even slowing some cancer cells.
Wow.
It's why high-dose statins are standard practice immediately after a heart attack or acute coronary syndrome, regardless of the starting cholesterol level. Those extra benefits kick in fast.
Chemically, are they all the same?
No, there are differences. Some are prodrugs like lovastatin and simvastatin, meaning they need to be activated in the body. Others are active as given. Most have high first-pass uptake by the liver, which targets their action nicely. They're mainly excreted in bile. Half-lives vary, with atorvastatin, pitavastatin, and rosuvastatin lasting longer.
And how do they actually work? The mechanism of action?
They mimic a natural molecule in the cholesterol synthesis pathway. They partially block the enzyme HMG-CoA reductase, which is the main rate-limiting step in making cholesterol inside your cells.
Slows down the factory.
Exactly. Now, the key mechanism for lowering LDL is that by reducing cholesterol inside liver cells, they cause the cells to produce many more high-affinity LDL receptors on their surface.
More docks for the LDL ships.
Perfect analogy. More receptors mean the liver pulls LDL particles out of the blood much faster, along with their precursors like VLDL remnants. This dramatically lowers blood LDL levels. Their main effect is in the liver because of that first-pass uptake. They also cause a modest drop in triglycerides and a small rise in HDL.
And those rapid clinical benefits, the pleiotropic effects, how do they work?
It's thought they relate to reduced prenylation of certain proteins like Rho and Rab. Less prenylated Rho means less Rho kinase activity, which is involved in inflammation and plaque stability. This might explain why heart events decrease faster than plaques actually shrink. Reduced Rab prenylation might even have implications for Alzheimer's, but that's still being researched.
Fascinating. How are they typically used? Dosage.
Very versatile. Used alone or often combined with ezetimibe, PCSK9 inhibitors, resins, niacin, bempedoic acid for bigger LDL drops. If triglycerides are also high, a fibrate might be added. Most are best taken in the evening since cholesterol synthesis peaks at night, but the longer-acting ones offer more flexibility. Food helps absorption for most, except pravastatin and pitavastatin. Doses vary a lot between statins. Simvastatin 80 milligrams has specific warnings due to myopathy risk, and starting doses should be lower for people of North Asian ancestry.
Okay, let's talk toxicity. Liver issues are a concern.
Elevations in liver enzymes, a STALT, can happen, sometimes up to 3 times normal. Often it's intermittent and not harmful, but if levels persistently go higher or the patient has symptoms, the drug should be stopped. Need caution in lower doses in liver disease. Monitoring involves baseline tests, then maybe 1-2 months later, then yearly if stable. Heavy alcohol use increases risk.
What about metabolic effects? Diabetes risk?
There can be a very small increase in fasting blood sugar. A small number of people might develop some insulin resistance. Large studies show a slight but significant increase in new-onset type 2 diabetes, often those already pre-diabetic. For most people, the heart benefits vastly outweigh this small risk, but it's something to monitor.
And the muscle pain. Myopathy.
That's often the biggest concern for patients. Minor increases in CK, a muscle enzyme, are fairly common, especially with exercise, usually no big deal. But rarely you get marked CK elevations with muscle pain or weakness. That's myopathy. If not stopped, it could lead to rhabdomyolysis, severe muscle breakdown damaging the kidneys.
Does combining drugs increase risk?
Yes, significantly with certain combinations. There's also a genetic factor variations in the SLC01B1 gene, OATP1B1 transporter, increased risk for severe myopathy. If myopathy occurs, check CK, stop the drug. It usually reverses. Sometimes muscle pain happens even without high CK. And very rarely there are hypersensitivity syndromes like lupus-like reactions or a serious autoimmune myopathy that needs immunosuppression. Statins might be paused during serious illness or surgery, and definitely avoid red yeast rice supplements, unreliable dosing, and potential toxins.
Drug interactions seem really important here too.
Vital, because statins use different liver enzyme pathways. Lovastatin, simvastatin, atorvastatin use CYP3A4, fluvastatin, rosuvastatin, pitavastatin use CYP2C9, pravastatin uses other pathways.
So drugs blocking those enzymes are a problem.
Yes, inhibitors of CYP3A4, like certain antibiotics, antifungals, HIV drugs, or CYP2C9 can cause statin levels to rise, increasing myopathy risk. Conversely, enzyme inducers can lower statin levels. Pravastatin and rosuvastatin are often safer choices if CYP interactions are a concern. Even grapefruit juice affects 3A4 statins. And with fibrates, fenofibrate is preferred over gemfibrozil when combined with statins because of lower interaction risk.
Lots to consider. Okay, next class, fabric acid derivatives or fibrates. So it boosts fat breakdown.
Yes. A major effect is increasing fatty acid oxidation, burning fat in the liver and muscle. Increases LPL activity, decreases fat release from adipose tissue. This lowers VLDL. LDL reduction is modest. Sometimes LDL even goes up a bit if triglycerides drop sharply. HDL usually increases moderately.
Therapeutic uses. When are they most helpful?
Great for preventing pancreatitis and severe hypertriglyceridemia, especially VLDL dominant types. and in dyslipidaemia, also helpful for triglyceride issues caused by some HIV drugs. Gemfibrozil is usually 600 milligrams once and twice daily. Fenofibrate doses vary. Take with food. Triglyceride lowering is significant. Cardiovascular outcome data has been mixed, but more positive recently, especially with diabetes or metabolic syndrome. Remember, fenofibrate is preferred with statins.
Toxicity. Side effects.
Can include rashes, GI upset, myopathy, less than statins, but risk increases in combo. Arrhythmias, low potassium, elevated liver enzymes. Can potentiate anticoagulants, so need dose adjustments. Rare rhabdo. Avoid insignificant liver or kidney disease, though might help NAFLD. Slight increase in gallstone risk, so caution if prone to them.
Okay. Let's talk niacin. Vitamin B3. Seems like an oldie but a goodie.
It has a long history. Some older trials showed it could regress coronary plaques and even extend lifespan, but individual response varies a lot.
Pharmacokinetics. It's just a vitamin.
It is vitamin B3, converts to NAD, vital for energy. But at pharmacological doses, much higher than dietary, it strongly affects lipid metabolism. Excreted in urine, a metabolite can cause larger red blood cells sometimes.
What's its mechanism of action? How does it work on lipids?
It's multifaceted. It inhibits VLDL secretion from the liver, which indirectly lowers LDL. It increases VLDL clearance via LPL. It acutely increases cholesterol excretion. And uniquely, it decreases the breakdown rate of HDL, making it the most effective drug for raising HDL levels.
Wow, multiple actions.
Yes, plus it lowers fibrinogen, increases TPA, good for clots, and inhibits fat release from adipose tissue, likely reducing fatty acid flow to the liver.
Uses. When is it typically prescribed?
Often in combination with statins or resins for extra LDL lowering, can be very effective for severe mixed lipemia, especially with omega-3s. Useful in FCH and dyslipidemia. Best agent for raising HDL, and it lowers LPA too. Dosing needs to be gradual, starting low, rarely 100 milligram TID with meals, and increasing slowly to 1.5, 3.5 G day, maybe up to 4 G for FH. Extended release forms help with side effects.
Ah, yes, the side effects. Toxicity.
Yeah.
The infamous flush.
That's the most common one, yes. Cutaneous vasodilation, feeling warm. It's prostaglandin mediated. Taking aspirin 30 minutes before helps blunt it. Most people develop tolerance over time. Important to warn patients it's harmless and usually gets better.
Other issues.
Itching, rashes, dry skin. Acanthosis nigricans, dark stain patches, can occur, needs discontinuation. Nausea, abdominal discomfort, take with food, maybe antacids. Avoid in peptic ulcer disease. Reversible liver enzyme elevations can happen, need monitoring. Severe liver issues are rare, but linked specifically to older, sustained-release OTC forms, not the prescribed extended-release ones. Can impair glucose tolerance, raise uric acid, gout risk. Rarely, arrhythmias or macular edema, eye swelling, need to stop if those occur, can potentiate blood pressure meds.
Okay. Moving on to bile acid binding resins. Cholesterol, cholestyramine, cholecyvalin.
Right. These are used only for isolated high LDL. Big caveat, they can actually increase VLDL and triglycerides if those are already high.
How do they work? Chemistry.
They're large, insoluble, positively charged polymers, like plastic beads. They're not absorbed at all, stay entirely in the gut. They bind bile acids.
So the mechanism is just binding stuff in the gut.
Pretty much. They bind bile acids, preventing their reabsorption. This forces the liver to use up its cholesterol to make new bile acids via 7-alpha hydroxylase. This lowers liver cholesterol,
Which triggers?
triggers the liver to make more LDL receptors to pull cholesterol from the blood, lowers LDL. Interestingly, by binding bile acids, they might affect FXR receptors, which can slightly raise triglycerides but also improve glucose metabolism in diabetics via GLP-1.
But they won't work if you have no LDL receptors, like homozygous FH.
Correct. Useless in that case, but good if there's some residual function.
Uses. Dosage.
Good for a primary hypercholesterolemia, lower LDL by about 20%. If used in combined hyperlipidemia, might need a fibrate or niacin to control the triglycerides they can raise, often used in combination therapy. Also used for itching from cholestasis and even digitalis toxicity. Available as granules or tablets. Start low, go slow. Take 2-3 times daily with meals.
Toxicity. What are the side effects?
Most common. Constipation, bloating. Fiber helps. Avoid and diverticulitis, sometimes stomach upset or diarrhea. Rarely can affect vitamin K absorption, monitor INR with warfarin, or folic acid. Gallstone risk is theoretically higher, but rare in practice.
And drug interactions are a big deal here, too.
Huge! They can bind and prevent absorption of many drugs, digitalis, thiazides, warfarin, tetracycline, thyroxine, iron, pravastatin, fluvastatin, ezetimibe, folic acid, aspirin, many others.
The timing is crucial.
Absolutely. Take other meds 1 hour before or 2 hours after the resin. Colesevelum is a bit better. It doesn't bind digoxin, warfarin, or statins as much.
Okay, last one in this section. Inhibitors of intestinal sterol absorption, ezetimibe.
Right, ezetimibe. It blocks absorption of phytosterols, plant sterols, and cholesterol from the intestine. Adds nicely to statin therapy, lowers LDL further, even shown to reduce plaque size.
Pharmacokinetics.
Absorbed, converted to active form, circulates between liver and gut, enterohepatic circulation, mostly excreted in feces. Fibrates increase its levels, cholesterol reduces them, no major interactions with warfarin or digoxin.
Mechanism. How does it block absorption?
Very selectively inhibits a transport protein called NPC1L1 on intestinal cells. Works even if you don't eat cholesterol because it blocks reabsorption of cholesterol secreted in bile.
Clever. Uses.
Dosage. Standard dose is 10 milligrams daily. Alone lowers LDL about 18%. It's the drug of choice for phytosterolemia. Great synergy with statins can add another 25% or more LDL reduction on top of the statin effect.
Toxicity. Is it well tolerated?
Generally, yes. Not a CYP450 substrate, so fewer interactions. Low risk of reversible liver function issues, slightly higher with a statin. Rare reports of myositis.
What a comprehensive toolkit. It's amazing how these different mechanisms can be mixed and matched for individual patients. Truly personalized therapy.
Exactly. And the field isn't standing still. Beyond those established drugs, there's a wave of innovation providing even more targeted options. Let's look at the cutting edge.
Okay. First up, inhibition of microsomal triglyceride transfer protein, MTP. Lamidibide. What does MTP do?
MTP is essential for assembling VLDL in the liver and chylomicrons in the intestine, basically loading them up with triglycerides. So inhibiting MTP decreases secretion of these particles, which ultimately lowers LDL.
Uses.
Highly restricted use, only for homozygous FH because it's potent but has significant side effects.
Toxicity being.
Liver fat accumulation, elevated liver enzymes, requires a very low-fat diet to manage GI side effects like steatorrhea and careful monitoring for fat-soluble nutrient deficiencies. It's under a strict REMS program.
Got it. What about PCSK9 inhibition? This seems like a huge deal.
It really is. The breakthrough came from realizing people with natural loss of function, PCSK9 mutations, have incredibly low LDL and are perfectly healthy. That pinpointed PCSK9 as a target.
And how do the drugs work? Mechanism.
PCSK9 protein normally binds to the LDL receptor and targets it for destruction inside the cell. The main drugs now are monoclonal antibodies, evolocumab, that physically block PCSK9 from binding the receptor.
So the receptor doesn't get destroyed.
Exactly. It recycles back to the surface and keeps pulling LDL out of the blood. The effect is dramatic LDL reductions up to 70%. They also lower triglycerides, ApoB, and LPA by about 25%.
Jesus, who gets these?
Currently for FH or patients with established cardiovascular disease who need more LDL lowering than other therapies provide or can't tolerate statins. Big outcome trials show they significantly reduce heart attacks and strokes. Can be used alone or added to statins, ezetimibe bempedoic acid, given by subcutaneous injection maybe every 2 weeks or monthly.
Toxicity. Are they safe?
Generally very well tolerated, rare hypersensitivity, some injection site reactions, maybe mild flu-like symptoms. Muscle pain is rare, which is great for statin-intolerant folks.
And there's an even newer way to target PCSK9.
Yes, inclisiran, an RNAi inhibitor. It's a small interfering RNA. siRNA. Instead of blocking the protein, it silences the messenger RNA that makes the PCSK9 protein.
Stops it at the source.
Right. Reduces LDL by about 50%. The truly revolutionary part is the dosing just twice a year by injection. Huge for adherence.
Wow. Okay, what about ATP citrate lyase inhibition, bempedoic acid?
This one works upstream of statins in the cholesterol synthesis pathway, inhibiting ATP citrate lyase in the liver. So it reduces cholesterol production by itself and adds to the effect of a statin.
Any advantages?
Big one. Its activity is mostly liver-specific, so it's not expected to cause myopathy. Great potential for statin-intolerant patients. Main side effects are potential hyperuricemia and rare tendon rupture.
Okay. And angiopoietin-like 3 inhibition, evinacumab.
This is a monoclonal antibody targeting ANGPTL3, a protein that normally inhibits LPL and endothelial lipase, other fat-clearing enzymes. Blocking ANGPTL3 unleashes these enzymes.
Yes.
Restricted to homozygous FH patients, it lowers LDL by almost another 50% on top of other treatments, and importantly, it works even if they have no functional LDL receptors. A real game changer for them.
Amazing. What else is cooking? Agents under development.
Lots of exciting stuff. Antisense oligonucleotide inhibitors of LPA, like pelacarsen, look very promising. These drugs block the production of the LPA particle itself. Early data shows significant LPA lowering, reduced oxidized lipids, less inflammation, and few side effects so far. Clinical trials are ongoing, huge potential there.
Anything for triglycerides?
Yes. Volanoasorsen, an antisense oligonucleotide inhibitor of ApoC3, it blocks production of ApoC3, which inhibits LPL. Approved in the EU, not US yet. Lowers very high triglycerides in familial chylomicronemia syndrome significantly. Main toxicity concern has been low platelets, thrombocytopenia.
Well, what happened with CETP inhibitors? They were supposed to raise HDL.
They did raise HDL, often dramatically, by blocking the transfer of cholesterol esters. But the big lesson learned was that just accumulating large HDL particles didn't translate into the expected heart protection in large trials. So no drugs approved in this class currently. Function matters more than quantity. It really showcases the incredible pace of innovation. We're getting so much more precise, understanding the biology better, leading to tailored solutions for really complex cases. It's all about mastering the details.
Okay, let's put all this deep knowledge into practice. How does it look in a real patient? Let's walk through that case study. Remind us of the patient.
Right. We had a 52-year-old woman, history of high cholesterol since she was 19. Over the years, gained weight, not much exercise, diet high in fat and simple carbs.
What were her numbers when she came in?
LDL 155, triglycerides quite high at 458, HDL lowish at 40. LPA was normal, BMI 30, so obese. A1C 6.4%, pre-diabetic. ALT liver enzyme is about twice normal, suggesting fatty liver. No symptoms, but her coronary calcium score was positive, meaning early plaque buildup.
And family history?
Significant. Mom with type 2 diabetes, overweight. Dad had a heart attack at 47. Only known risk was high cholesterol. Both parents on statins.
Okay. What was the initial plan?
She got specific diet and exercise advice. Started on 20 milligrams of a statin, a strong statin, plus marine omega-3s for the triglycerides.
How did she do after 3 months?
Good progress. Lost 6 pounds, sticking to the plan. LDL dropped to 97, triglycerides down to 340, HDL up slightly to 45, A1C improved to 5.8%, but the ALT didn't change, still suggesting fatty liver.
So putting on our expert hats now, how do we analyze this? What's the likely diagnosis and the next steps?
Given everything, the lifelong high lipids, the pattern of high LDL and high VLDL triglycerides, the obesity, prediabetes, strong family history, the most likely diagnosis is familial combined hyperlipoproteinemia, FCH. Both lipid types contributing to risk, amplified by the metabolic issues. Fatty liver is almost certainly present.
And the treatment goals.
Because of that positive calcium score, the FCH, low HDL, and her dad's early heart attack, her LDL goal needs to be aggressive, aiming for around 50 milli-GDL.
How did they get there?
She was given the choice, increase the statin or add ezetimibe. She chose to add ezetimibe.
And the result?
After 2 more months, LDL was down to 58, triglycerides 305, closer but not quite there, especially the triglycerides. So fenofibrate was added.
The triple therapy.
Yes. And after another 3 months, impressive results. Triglycerides 95, LDL 53, HDL 49. Pretty much optimal. Stable numbers 4 months later, too.
What about the other issues? The A1C, the liver?
This is where lifestyle really paid off. Continued diet, exercise, weight loss led to her A1C normalizing to 5.6%, and crucially, her ALT finally became normal. Fatty liver resolved.
Fantastic. Future plans.
If her A1C creeps up again, metformin would be considered. She'll also likely take breaks from the fibrate periodically and monitor triglycerides, showing that dynamic management approach.
This case perfectly illustrates how all these pieces, the underlying biology, the different drug classes, the lifestyle foundation, fit together in real-world practice.
Exactly. It shows that iterative process. You assess, you treat, you reassess, you adjust based on response and the changing risk profile. That's the hallmark of mastering this field, truly elite practice. Hashtag tag outro.
Wow. Okay, this deep dive has definitely shown us that managing lipids is so much more than just looking at one number on a lab test. It's really a dynamic, personalized journey.
It absolutely is. It involves understanding this intricate biology, knowing how to use this powerful arsenal of medications effectively, and never forgetting the fundamental importance of those lifestyle choices. They all interact constantly.
And it seems like the field is moving so fast.
Incredibly fast. As we keep unraveling the complexities of human metabolism, genetics, the future really points towards even more precise, individualized treatments. Leveraging that deeper scientific understanding is key.
So the final question for everyone listening.
Yeah, the question really becomes, for you, how will this deeper understanding we've explored today inform your next step? How will it help you in mastering your own health journey, or perhaps in guiding the health journey of those you care about?